Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. Today, I have the great pleasure of having on the podcast Dr. Núria Agustí, who is in the Department of Gynecologic Oncology and Reproductive Medicine at the University of Texas MD Anderson Cancer Center here in Houston, Texas. And the reason for this podcast is we're going to be talking about a very important, very interesting study that was published in JAMA Network Open, titled Surgical De-escalation within Gynecologic Oncology. So a very timely topic, and really looking forward to her discussion. And I want to congratulate her for that publication, along with all the co-authors as well. So Núria, it's great to see you again. Thank you so much for joining our podcast and accepting our invitation.
Yeah, thank you so much, Pedro. I'm very grateful for the opportunity to discuss what I think such a relevant topic, especially at the time when surgical practice in our field are evolving so rapidly. And it's truly a pleasure to be here, both as a former fellow, where I had the opportunity to further develop my research skills, and also on behalf of the team I'm working with, who make all these projects also possible. So thank you.
Yeah, no, and I should say, Núria, congratulations to you. I mean, many years ago, you visited me at MD Anderson, and since that time, I mean, you really have flourished professionally, academically. So very, very proud, and again, congratulations on all your work.
Thank you so much. I appreciate your words.
So, Núria, on this topic, lots of questions, and as you said, incredibly timely. So let's just start by defining what you mean by de-escalation, and why is this a relevant term today in gynecologic oncology?
Yes, so yeah, it's a good question to get started. De-escalation in gynecologic oncology is about reducing the extent of surgery while still maintaining oncologic safety. So the idea is pretty simple. If we can achieve the same cancer control with less invasive procedures, such as fewer lymph nodes dissection and organ preservation, so why not choose the approach that also improves quality of life? So, for a long time, the approach in gynecologic cancers was based on the idea that more surgery is better, but the belief that more radical procedures would lead to better survival, and for the belief that more radical procedures would lead to better survival outcomes. However, over the years, data from randomized trials, retrospective studies, and also real world evidence have shown that a more tailored approach can be just as effective. And in fact, we have already seen this happening in breast cancer, where less aggressive surgery combined with medical therapy has become a standard in practice without compromising outcomes. So the shift towards de-escalation is more relevant than ever as oncologic care continues to evolve towards a patient-centered model. And the goal is not just to cure cancer, but is also to minimize long-term complication, reduce unnecessary morbidity, and also improve overall well-being. And at the end, it's about finding the right balance. I would say offering less aggressive treatments when safe, but of course, still ensuring that radical surgery is available when truly needed.
So then, Núria, how did you gather the data for this study? And can you tell us about the study design? Specifically, how did you define de-escalation for the purposes of this study?
Yes, so in this study, we look at de-escalation in three main ways. The first one was the surgical approach, in which we analyze how often minimally invasive surgery was being used instead of traditional open approach. Secondly, we looked at lymph node evaluation, in which we examined the shift from full lymphadenectomy to the sentinel lymph node biopsy. And finally, we also look at the extent of surgery, in which we consider patients where fertility-sparing procedures were performed or where unnecessary organ or tissue removal was avoided. Regarding the study design, this is a retrospective cohort analysis using prospectively collected data from the National Cancer Database, and specifically, we included women diagnosed with clinical stage 1 to 4 with endometrial, ovarian, cervical, or vulvar cancer between 2004 and 2020. However, since our analysis, as you can see, included all gynecological cancers and all the stages, and each cancer type has its own characteristics, we needed to assess the de-escalation trends individually for each cancer type. So to do so, we selected subgroups aligned with the evolving NCCN guidelines over the study period. And basically, this approach allowed us to establish a clear rationale for selecting each cohort based on the specific considerations for each cancer type. So, for example, when evaluating the surgical approach, we looked at the use of MIS or open surgery to every cancer site, except, of course, for vulvar cancer. And instead, when assessing the lymph node evaluation, we had to further refine our analysis. And for ovarian cancer, for example, we distinguish between early and advanced stage GC as we consider it pertinent. But for example, in endometrial cancer, what we did is dividing patients into 3 risk groups to evaluate if sentinel lymph node was first adopted, mainly in low-risk patients, before expanding to higher risk groups. And finally, regarding, for example, the extent of surgery, in cervical cancer, we differentiated between simple and radical hysterectomy. But of course, it does not apply to ovarian or endometrial cancer. So those are only examples to kind of illustrate how tailoring our selection criteria and analysis to each cancer type just ensure that our evaluation of the de-escalation trend was both comprehensive and also accurate.
Excellent. And what was the primary objective of this study specifically?
Yeah, so the primary objective was to evaluate adoption of surgical de-escalations within the field of gynecologic oncology using the National Cancer Database, including endometrial, ovarian, cervical, and vulval cancers.
Fantastic. So quite a large number of patients. I'd love to hear the results of the study. What are some of the things you want to highlight from the study?
Yeah, so this is a broad study, and there are several key takeaways that I will try to sum it up. So the key takeaway from our study, it's clear the trend of surgical de-escalation across all gynecologic cancers. First, overall surgery rates declined significantly across all gynecological cancers. And for example, in cervical cancer, surgical treatment dropped from 47% to 40%. In ovarian cancer, the same, dropped from 72% to 68%. In endometrial cancer, it dropped from 84% to 79%. And finally, in vulvar cancer, it dropped from 81% to 72%. When we look at the surgical approach, minimal invasive surgery has increased significantly, especially in endometrial cancer, where it went from 45% to 82% by 2020. And surprisingly, also in ovarian cancer, it raised from 13% to 37% by 2020. However, as you can imagine, in cervical cancer was a bit different, and although MIS use initially peaked at 70% in 2017, then it dropped to 50% by 2020, likely to the impact of the LAG trial findings. And regarding the lymph node evaluation, we saw a significant shift towards sentinel lymph node biopsy, particularly in endometrial cancer, where its use increased from almost 0 to nearly 40%. In cervical cancer, the adoption was lower, reaching over 15% by 2020. And additionally, regarding parotid lymphadenectomies for staging purposes, declined over time. However, they were already rarely performed even in locally advanced cervical cancer at the beginning of the study period in 2004. Now, finally, when it comes to surgical extent, the picture is quite less clear, but what we do see clearly is that in cervical cancer, fertility-sparing surgeries in younger patients increased from 17% to 28%. So in the end, we are seeing, I believe, like a clear pattern of surgical de-escalation with increasing adoption of MIS and lymph node mapping, but also exceptions regarding the de-escalation in the radicality of the surgeries.
Excellent. So Núria, as you know and remember from your fellowship in the journal, We always ask questions that come directly from the fellows. First one is Stephanie Gill from the University of Toronto, and she's asking, from all the data, was there any trend in de-escalation that you found particularly interesting or surprising? And if so, why?
Yeah. Yes, so one particularly interesting trend was, as I was mentioning in the previous question, the overall reduction in the number of surgery performed across all gynecologic cancers. So I think that this decline likely reflects a shift toward alternative treatment modalities, such as neoadjuvant chemotherapy and molecular targeted therapies, which help identify patients who might not benefit from surgery, along with the increasing use of upfront chemoradiation as a primary approach in certain patients. Second, while we expected to see surgeries being performed less often, we also saw a clear rise in minimally invasive surgery, which was reassuring. But there were also some surprising trends, like the increased use of MIS in ovarian cancer, even in advanced stage disease. And this was quite unexpected, especially since we are still waiting for randomized evidence to support its oncologic safety. And third, another interesting point was the discrepancy in the uptake of sentinel lymph node and dissection. So while in endometrial and vulval cancer, it increased substantially, its adoption in cervical cancer was much lower than anticipated. Interestingly, also, I'd like to know that radical hysterectomy rates in cervical cancer actually increased, while simple hysterectomy rates declined over the period time of the study. So this might seem, at least for me, counterintuitive, but I think that it might be explained by the fact that before 2020, the SHAPE trial had not yet been published, and clinicians were likely maybe adhering more strictly to existing guidelines over the years. So I'm not sure, but it's my hypothesis. And finally, ovarian preservation in endometrial cancer also decreased, despite clear guidelines recommending its consideration in low-risk patients.
Very interesting. So one of the other interesting points, you mentioned in the study that sentinel lymph node dissection in patients with cervical cancer went from 0.2% to 10.6%. You know, and it seems that the uptake in sentinel lymph node mapping is just barely been integrated when in fact, you know, frankly, in the United States, I'm not aware of any institution that is routinely performing complete lymphadenectomy in early cervical cancer. So in other words, the fact that sentinel lymph node mapping as represented by the studies being done in only 10.6% of patients, I found that surprising, and I would anticipate that it'll be close to like 100% of patients undergoing sentinel lymph node mapping in cervical cancer. So wanted to hear your thoughts on that.
Yeah, honestly, all the team was also surprised for those findings. And I would say that despite the assumption that most institutions have moved away from routine complete lymphadenectomy in cervical cancer, clearly our data suggests that sentinel lymph node mapping remains lower than anticipated. And one possible explanation is that there is still a limited body of evidence demonstrating its safety in terms of oncological outcomes, which in fact is why ESGO guidelines continue to kind of support lymphadenectomy. So I don't know, maybe some clinicians might still prefer full lymphadenectomy until stronger survival data is published. Moreover, we have to acknowledge that the national database also has some variables that are underreported. So in fact, we try to overcome this issue, and doing another kind of analysis, counting the lymph nodes, we saw that the uptake for performing sentinel lymph node in cervical cancer increased by approximately 5 to 10%, but is still low rates. And lastly, some centers may have been in the process of adopting sentinel lymph node mapping at a lower rate. And during the learning curve, even when sentinel lymph node mapping is performed, a complete lymphadenectomy is carried out for validation. So in those specific cases, we classified them as lymphadenectomies because, they were still performing lymphadenectomy. However, the true uptake of sentinel lymph node mapping might have been also underestimated. And also, I would like to know that endometrial cancer, the rates were about 40%. So, we clearly think sometimes that everybody is following the guidelines, but In fact, there are included over 1,500% of accredited centers in the National Cancer Database. So probably not everywhere they are still using the sentinel lymph nodes technique, although we are assuming that they are following the guidelines and they are just adhering to the new techniques. So I think that at the end, it's a real world data, and it's something that we also have to learn from.
Okay. This question comes from Julia Gellison in the University of Wisconsin in Madison. Why do you think rates of fertility-sparing surgery for endometrial cancer decreased and rates of ovarian removal at the time of hysterectomy for endometrial cancer increased over this period, while rates of fertility-sparing surgery increased for cervical cancer?
Yeah. So in our study, we examined fertility-sparing surgery in cervical cancer, but unfortunately for endometrial cancer, our focus was different. And in fact, we specifically looked at ovarian preservation as a surrogate of surgical extent in long-term morbidity. Since the National Cancer Database does not capture the uterine sparing approaches with progestations, our analysis in endometrial cancer was limited to assessing whether the ovaries were retained in women under 40 years with a stage 1 endometrioid histology. Despite evidence I was mentioning before showing that ovarian retention does not negatively impact oncologic outcomes in patients with low-risk disease, we observed a significant decline in ovarian preservation from 11% to 3.5% in 2020. So this trend likely reflects oncologic caution in endometrial cancer, and I would also say that physicians may also feel reassured that patients can still receive hormonal treatment post-surgery. And in fact, similar trends were seen in cervical cancers, because among patients with stage 1 cervical cancer, squamous histology, and under the age of 45 years, the trends mirrored those in endometrial cancer and also showed a progressive decline in ovarian preservation over the time.
So this question comes from Christian Braun in Lucerne Hospital. Have you conducted a subgroup analysis comparing academic versus non-academic centers to evaluate whether the adoption of minimally invasive techniques in sentinel lymph node biopsy have evolved differently between these two types of institutions?
Yeah, precisely. In fact, it has not been published yet, but in a continuation study examining specifically cervical cancer, we found that being an academic center did not have a significant impact on the speed of adopting sentinel lymph node mapping. On the contrary, being a high volume center was more of the likely to adopt the technique. So this suggests that it was not the academic affiliation, but rather the volume of patients treated that determined the faster adoption, likely due to the learning curve, maybe also because centers progressively incorporate sentinel lymph node mapping as they gain experience with the procedure. But it was directly linked to the volume of patients treated and not being or not an academic affiliation.
Very well. Thomas Bartle from Medical University of Vienna is asking, could improvements in diagnostic methods and shifts in age distribution have influenced the observed trends? For example, could earlier diagnoses have been more frequently referred to minimally invasive surgery, and also older patients were deemed unfit for open surgery, so that relative age and stage distribution remained stable throughout the study period?
Yes, thank you. So it's a long question. I I will try to divide my responses. While we have not specifically looked at changes in age distribution, we do have yearly data on a stage distribution for each cancer type. And I would say that the explanation likely varies depending on the cancer type. So, for example, for endometrial cancer, early stage diagnoses have increased over time, while the number of advanced stage patients has remained relatively stable. So that could be linked to better detection, but personally, I don't think it fully explains why surgical rates have gone down. More likely, it might have due to with the growing use of targeted therapies and immunotherapy for advanced or recurrent disease, which has reduced the need for extensive surgeries, especially in frail patients who now might have better medical treatment options than they did actually in the past. Also, for cervical cancer, both early and late stages, patients have actually declined, probably thanks to screening programs and HPV vaccination. But another key factor might be the shift towards definitive chemoradiation for more advanced patients, particularly as radiotherapy techniques have improved. And somehow this explanation could also be applied in vulvar cancer patients. And finally, for ovarian cancer, staging has remained also fairly stable until around 2020, meaning that the drop in surgeries is not really due to a shift in stage distribution. Instead, I would say again, it's likely a result of the increasing role of neoadjuvant chemotherapy and also targeted therapies. So probably some patients never make it to surgery, either because they don't respond well to chemotherapy or because they are considered too high risk afterwards. And at the same time, we are seeing more MIS procedures, which might be linked to the rise in neoadjuvant chemotherapy, especially as randomized trials have shown no significant differences in outcomes between upfront surgery and neoadjuvant chemotherapy.
Very well. So this question is pertaining to cervical cancer from Matteo Marchetti, University of Padua. And he says, your study shows that the use of minimally invasive surgery for cervical cancer initially increased until 2017, but then it declined significantly after the publication of the LAC trial. Did you conduct any subgroup analyses to examine how this trend evolved specifically in patients with tumors larger than 2 centimeters? Are there any indications as to the decline in minimally invasive surgery in this subgroup of patients?
Yeah, I mean, it's a great question, and I do think it's an important topic. The use of minimally invasive surgery for cervical cancer kept increasing until 2017, but after the LAC trial was published, we saw like a sharp decline, dropping about 20% by 2020, and I think likely even more by 2025, this current year, since guideline changes, take time sometimes to be fully implemented. And it's true that while we have not specifically analyzed how these trends evolved in tumors larger than 2 centimeters, it's something that we are actually actively looking into. And that being said, even though MIS has declined, it's still being performed. We have seen that by 2020, 50% of the surgeries were performed by MIS. So I think that it could be because first, some patients may involve tumors smaller than 2 centimeters, where surgeons might still see MIS as a reasonable option, especially for low-risk patients. And second, I also think that robotic surgery might be playing a role. LAC trial had few patients included operated by robot. And now the ROC trial is actively studying whether robotic radical hysterectomy is oncologically safe compared to open surgery. So maybe some centers may still be using robotic MIS while still waiting for those specific definitive results. And finally, another reason that we know that it happens is that patients who were incidentally diagnosed with cervical cancer after a hysterectomy for benign reasons, those patients were not originally planned as cancer surgeries, so MIS might still be used in these situations. So I would say that although we have not performed this analysis for tumors greater than 2 centimeters, we try to figure out why after LAC trial there were still 50% of patients being operated by MIS, which honestly also surprised us. And those were our hypotheses, at least.
Yeah, and I think also it's a matter of time trend. When we looked in our manuscript that Gabriela Schivardi wrote, you're absolutely right. By 2020, it's about 50% of patients undergoing minimally invasive surgery. But just 2 years later, it went from 50% to 11%. So in 2022, there were only about 11% of patients undergoing minimally invasive surgery. I suspect now in 2024 or 2025 that those numbers will be even less. So yeah, I mean, I think it's just when we actually stop the time trend evaluation. So now Julia Gellison, again from the University of Wisconsin, she's asking, how did you determine the sensitivity of 90 to 97% for defining sentinel lymph node dissection versus lymphadenectomy based on number of lymph nodes removed? What methods were used to confirm this?
Yes, so to analyze the sentinel lymph node traits, we first relied on the National Cancer Database explicit coding, which distinguishes clearly between sentinel lymph node biopsy and lymphadenectomy. However, since sentinel lymph node coding we know that can sometimes be underreported and it's a limitation, we cross-referenced it with the actual number of lymph nodes examined in pathology. Specifically, we looked at patients where sentinel lymph node was explicitly reported, and we checked whether those patients with sentinel lymph node variable reported has fewer than 4 lymph nodes removed, as expected for a sentinel lymph node procedure. And similarly, for patients coded as lymphadenectomy, we verified that they had 4 or more lymph nodes removed. So when we did this comparison, we found that in about 90 to 97% of patients, the classification based on lymph node counts matched the reported sentinel lymph node variable. So somehow this gave us confidence that using the number of nodes examined was a reliable way to identify sentinel lymph node procedures when explicit coding was missing.
So now, Núria, I was going to ask a question from Kara Fisher at University Hospital in Heidelberg. So how do the authors rate the increase of minimally invasive surgery in ovarian cancer patients, taking into account that non-inferiority has not yet been proven? In other words, why is there this increase without any data to support minimally invasive surgery in ovarian cancer?
Yeah, so this is a very interesting question. And as I was mentioning, there is not actually any clinical trial showing if it's oncologically safe, or at least it has non-inferiority compared to the open approach. So I do think that, however, there is retrospective evidence. In fact, our team also performed a couple of years ago a study from the National Cancer Database in which they saw that while there were less morbidity, the overall survival was remained the same. So I would say that somehow also we are relying on this retrospective data. However, I do think that we should be cautious because we don't have the results of the Lance trial. Is the current clinical trial who is looking at those outcomes. And in the meantime, while I think that, of course, there's retrospective data showing support to use minimally invasive in certain low-risk patients, caution is needed because we still have an ongoing trial and we should also wait for the results, because as you know, LAC trial also, we expected another result and at the end it ended up having unexpected outcomes. So I do think that we should adhere to clinical trials results, and of course we should be cautious in this increased use in minimally invasive surgery.
Right. Now, Mateo Marchetti is asking, the discussion mentions disparities in the implementation of minimally invasive surgery and sentinel lymph node evaluation across different demographic groups. So in low-income countries where access to high-cost equipment and specialized training is limited, do you think surgical de-escalation techniques such as sentinel lymph node biopsy could actually widen the gap in care, or could they provide a cost-effective alternative to traditional radical procedures?
Yeah, that's a good question. And I think it really depends on which aspect of de-escalation you are looking at. For example, for minimally invasive surgery, the reliance on expensive equipment, especially robotic systems, makes access more difficult in low-income countries. So yeah, I think that this could widen the gap in surgical care between high and low resources settings. And for sentinel lymph node evaluation, many centers in lower resources settings use methylene blue because it's more affordable. However, it's true that it has lower overall and bilateral migration rates compared to technetium or indocyanine green, and it might end up increasing the need for full lymphadenectomy. And while MIS might be harder to implement in low risk low resources settings, I do think that sentinel lymph node evaluation using it's more accessible because it has low cost methods, and it could have cost effective alternatives to traditional radical approach. And finally, when it comes to surgical extent or fertility spreading strategies, this depends more on surgeon expertise and clinical decision making rather than expensive equipment. So they shouldn't be as affected by resources limitation.
So Nuria, this is a question that was asked practically by all fellows. As these de-escalation procedures become standard, do you foresee a potential loss of expertise in performing radical surgery? So what will be the impact on training when you're saying basically we're no longer doing the really big aggressive procedures and we're moving towards a much less complex procedures?
Yeah, honestly, I'm also kind of concerned because I do think there is a real concern that all the fellows have currently about the loss of, of expertise in complex open surgeries. And I think that the challenge is ensuring that surgeons in training still develop necessary skills for radical procedures, which in fact still remain essential in certain cases, indicated cases. So, for example, I think that radical hysterectomy is essential for mastering pelvic anatomy, while, for example, para-aortic lymphadenectomy helps surgeons develop expertise in the retroperitoneum. But it's true that as radical surgeries become less common, and also, I mean, maintaining proficiency in these techniques, it's becoming harder. I think that it's especially important for patients. For example, you still can indicate a radical hysterectomy, so it's still necessary. And you can also have the indication of, removing a retroperitoneal mass. Or, for example, in early stage ovarian cancer, where full staging is still indicated in some patients, you still need to have this expertise. So yeah, without regular exposure to these procedures, I do think that the ability to navigate to complex pelvic anatomy or the retroperitoneum could decline over time, and I understand that it might be a concern. So regarding how to balance this shift, I think that training programs have to adapt to this shift, and some key strategies, probably I'm missing other strategies that might be also useful, but some strategies could be like centralizing complex surgeries in high volume centers, so trainees get hands-on experience under expert mentorship. Also, I think that it would be worth incorporating extended rotations in related specialties like urology or general surgery, just to develop more complex surgical skills, and also enhancing even more simulation training and cadaveric workshops might be another possibility.
So Nuria, what do you see as the main limitations of this study?
Yeah, so I think that the main limitation of this study comes from using a retrospective database, which has some gaps in available data. First, there are restrictions in coding in detail of the database. So, for example, in ovarian cancer, the database doesn't capture well certain radical procedures, so we could not fully assess the extent of surgery in advanced stage patients. And for example, in endometrial cancer, we didn't assess the fertility sparing rates because, I mean, we cannot assess the uptake of progesterone. And second, there might be limitations also in defining, for example, fertility sparing surgery. We use the definition based on retaining uterus and at least one ovary, but it means that maybe some patients had already lost an ovary before surgery. So this could affect how fertility preservation is interpreted in a few number of patients in this situation. Third, it's a large database and relies on consistent coding across multiple centers, but errors occur like undercoding, sentinel lymph node biopsies, as we were mentioning before. And finally, regarding specifically in this study, the goal was to provide a broad overview of the trends in gynecologic oncology. So some specific details were not explored in depth. That said, we are actively working on ongoing subgroup analysis, and this might help answer some of the questions that some of the fellows also had, and I was not able to respond. And yeah, hopefully we will have more results shortly.
Excellent. So one last question from Elise Yates here in Houston Methodist. Would you anticipate similar results if this study had been evaluating patients on a global scale rather than just in the United States?
Yeah, I mean, absolutely not. the results, I think, that would likely be quite different on a global scale due to variation in patients' population, in surgical skill strengths, in clinical guidelines, in healthcare resources. So, for example, in countries where radiotherapy is not widely accessible for cervical cancer, surgeons may opt for more radical procedures in cases where a less aggressive approach would instead have been preferred in another country. And similarly, as I have previously mentioned, if a country that has maybe another kind of tracer for sentinel lymph node evaluation, the lower detection rate that it has may lead to perform more lymphadenectomies. So it's more difficult to de-escalate this procedure. And finally, for example, in the settings where a follow-up for a patient is less reliable, offering, for example, a fertility-sparing surgery might not always be indicated or feasible. So yeah, in short, guidelines, cultural factors, medical resources, all shape surgical trends, meaning that the global picture would likely look quite different from what we observe here in the United States.
Excellent. So, Núria, thank you so much. Always a pleasure speaking with you. Really great paper. Very exciting topic. In fact, I should announce that the special issue for March of 2026 is going to be titled De-escalation in Gynecologic Oncology. So obviously a very hot topic, and we're really appreciative of having the opportunity to discuss this with you. Once again, congratulations to you, to all the co-authors, and continue your great work. Really extremely proud of you, and I really look forward to all the things that are to come from your future academic career.
Thank you so much. I really appreciate the opportunity. I'm excited to share our work because I do think it's interesting and much more work is coming up. Thank you so much.